So hi everybody, I'm Brad Power, and this is, I think, update number 9. What time flies. And the format we'll have is as usual. We'll have a quick summary update from Linnea on how things are going, and we'll have sort of a formal part of the conversation, and then we'll spend the lion's share of today's call for those that are able to stay and refine the spreadsheet that Kimmery set up for what to do with the tissue, the instructions, and what have you, such that Linnea can forward that to her oncologist and pathologist, Dr. How do you pronounce it, Linnea? Eophrate?
If I say Euphrates, I don't know if that's correct.
Dr. Eophrate. And so there's several people on this call who are contributors and have said they're willing to offer their tests on that biopsy, and we'll be making sure that we're refining and filling out that table. So I'll be putting that on screen. But first, let's get an update from Linnea on where things stand.
Well, it's been a busy week where I have been doing all of the preamble to getting into a clinical trial, which means an echocardiogram, an EKG, and did I say that right? Most importantly, the eye exam to make sure my retina's checked out, and they were good. My labs, today I have a brain MRI and more labs. And Monday morning, I have to get a COVID test. And then I have the biopsy on Wednesday. And they have me slated right now to start the trial on Thursday.
Wow.
And, it's all just going so fast. And I put something on Facebook last night that sort of sums up where I'm at right now, which said, how to explain that you feel extraordinarily fortunate, 6 phase 1 clinical trial, while also feeling incredibly fucked, 6 phase 1 clinical trial. There are no words. So I've gotten to that place where I'm starting to feel a little anxious and yet ready to go to another rodeo. So.
Okay. I guess sobering, as you would say. Right. So I'm trying to think about where to break between the formal part and the discussion on and trying to fill out the form. Maybe Kimmery, since you were so gracious as to kind of kick this off and sort of laying out the columns in the chart, maybe just sort of set up your thoughts and intentions with what we're doing to try and make it as easy as possible for Linnea to request, give instructions to the pathologist and so on.
Sure. I'm assuming everyone on the call has access to that link or has already seen it or contributed to it.
Yeah, I'm going to call it up. I'm going to do a share screen with it in a minute. But yes, I have. I think it's in the Slack, and I think everybody here at one point or another, I've given them that link.
Okay, great. So I think the idea of putting together the table was really just to capture kind of all the brainstorming that's been happening over the last few weeks, and really kind of putting things into the table based on what is already kind of committed and promised versus things we're still exploring, and really getting a sense of what kind of tissue is required, what are even the specs on ideal tissue handling, and certainly the amount of tissue, which really is probably going to be the most critical thing, so that we can have it all laid out and then start making some critical decisions. At least, I guess my thinking is the idea that we have a discussion with as a team and sort of equip Linnea going in to talk to her clinicians about her feelings about where the tissue should go, in some kind of a rank order, at least in her mind, based on at least the best recommendations from this group. And there are some notes in there too about like getting a little bit more granular than most a typical patient would in terms of, and I was talking to someone from Caris Life Sciences yesterday, the MSL, Jamie, who knows you, Linnea, and was actually quite excited that I was talking to her about someone she knew. But she was saying things like, just because we say we need, 25 slides, it doesn't mean if you don't have that you shouldn't still send it, So that was kind of my point about, oh, there's Jamie. There you are. So the point was, making sure that we know kind of the cellularity too of the tissue samples before we just send out based on what might say on a website or a request sheet for that tissue set, so that we make the most of it. So I'll stop there.
Okay. Before I stop the recording and we go to the document and working through it, any other questions or comments from anyone before we start that process?
I want to make one comment, and that is that the one thing I'm completely determined to have happen is when I go on Wednesday, I'm going to tell that surgeon that I will lay on that table as long as necessary. Get what you can, because there is a wealth of cancer in there right now. So there should be no lack of that. It's just a matter of what they can do safely. But I want them to push it as far as they can.
Got it. So we don't have to think about the constraint of allocating tissue to this one or that one. We'll take all the tests that are possible because we will assume that we'll have enough tissue. Got it. Well, that saves one stream of conversation. Any other questions or comments before I break?
Yeah, this is Rick. I was I reached out to Akoya Biosciences and also NanoString. They both need like a tissue, and this is kind of to Kimmery. I have no idea whether the biopsy that Linnea is considering is a fine needle aspirate, or whether that she could get a section of tissue that would be like a cover slip of 4 to 10 I guess microns, but that's what they typically use. And so they meaning I think this is kind of standard for folks doing immune expression, and Akoya would open up an avenue to new possibilities of immunotherapy decision making, as well as NanoString. I'll finish in just a second. I think NanoString could be, we could possibly get it for free. I was getting outrageously low quotes when I was with Human Longevity, and they were willing to work with us. And I know Mark Winham, senior, I think he's the chief operating officer of NanoString. Now for Akoya, it's a spatial consideration, and it's standard expensive. It's like $5,000 for their analysis on a slide. So my question is this even the kind of tissue that we can get? Would we, and if so, would we have interest? And if we can't get that tissue, then it's a very short conversation. What do you think, Kim? Marie?
I don't think I'm the actual expert to answer that question, but I think it does leave the question around, certainly we don't want to exhaust even if Linnea does, if they're able to get as many cores, hopefully. I mean, I'm hoping we're talking about cores here and not FNA. We certainly want to leave some left for other things. And I keep bringing up again, like before tissue is used in an assay, make sure there are digital images taken of those tissues as well. And, I would even advocate for making sure there's an unstained slide.
This meeting is being recorded.
I muted your other person, Erica. There we
I'm
go.
so sorry. I didn't mean to do that.
Yeah, I know. No worries.
Putting aside even an unstained slide, because there's a lot going on now with virtual staining and hyperspectral autofluorescence and things like that, which is a little bit too far beyond where we need to go with this right now, but it's certainly something on the horizon. So yeah, I mean, I hope we're getting cores, and I know that there are some assays listed on the table that speak about fresh tissue or really rapid and mailing on dry ice to France and things like that. I mean, certainly if tissue is limited, that may not be our first choice assay. So I think those are the kinds of things I think we should talk about if tissue is going to be limited, unfortunately, what would be the prioritization just in the event that that kind of happens. Otherwise, yeah, we've got a lot of things lined up and a lot of good assays that could be done.
Okay, I'm going to stop recording. We're at 15 minutes.